The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan, and thanks for listening in. It's a pleasure to be hosting the podcast. Wanted to thank everyone for direct messaging me on LinkedIn, as well as commenting about a recent podcast I did on my daughter's brain surgery. It was entitled, "My Courageous Daughter is Having Brain Surgery," and it essentially was about an hour-long podcast. It came out on April 19th. And a lot of great enthusiasm and comments about it. We got a great deal of credit for sort of outlining the fact that people that are underinsured or uninsured would just have a devastating time navigating the system and affording a major surgery, and some of the bills that they may be looking at if they were not well insured or if they were uninsured. And so my daughter was blessed to have great insurance, but we wanted to bring that message to everyone. So if you have not had a chance yet to listen to My Courageous Daughter is Having Brain Surgery, please listen in on the April 19th podcast. There was also 4 blogs we wrote on her surgery at the blog tab of healthcarelabyrinth.com as well. As usual, we will take a couple of breaks, 2 breaks here, with 2 different ads to break up the podcast a bit. And we will start today and just sort of explain a little bit about our topic. So the topic of the day is the No Surprises Act that has now been in place for several years. And we're going to talk a little bit about the good and the bad of the No Surprises Act, and a recent study that shows that this arbitration system very much favors providers and actually may drive up costs in the system over time. So this should be a relatively short podcast this week because it's sort of a tailored agenda here. So we'll get right to it. So what is the No Surprises Act? Well, it was passed in late 2020 in the twilight of the Trump administration by Congress and sort of an omnibus final healthcare bill out there. There was rising concern that people were getting a whole bunch of surprise bills out there. Now, it's important to remember that the No Surprises Act will not end surprise billing. Many people do not have an out-of-network benefit in their plan, and they go to out-of-network doctors, knowingly or not. So some of those situations where you go to an out-of-network doctor or even go to someone for an uncovered service that is not a part of your plan benefit, you'll always have surprise bills out there hitting you. And what's most important to remember about surprise bills is none of the negotiated rates that you normally see from your insurer apply. A provider in an out-of-network situation can charge what they want. And what we know about provider billed charges, which is what they would normally bill someone that is uninsured, is they're absolutely outrageous. They're not really based in fact or based in cost. They're sort of arbitrarily amounts of monies that they want to charge somebody without insurance for the privilege of providing a service. But again, it's not based in any kind of cost. And generally speaking, these very high billed charges from providers are really set out there to really be leveraged with health plans to essentially get the best payment from a health plan possible. So a billed charges will be very, very high, and a health plan will then negotiate from there to drive down through a discount to a lower rate. But what really happens with billed charges each and every year is they tend to go up and up and up by providers. And in so doing, they tend to drive up discounted negotiated rates with insurers as well. But if you get one of those surprise bills in the mail, you're again paying likely a billed charge, which is exponentially higher than what a commercial insurer would even pay, and especially what a Medicaid or Medicare provider would pay for sure. Now, the No Surprises Act does pull back the number of surprise bills that people will see in the country. And this is a good thing. I was an advocate of solving this problem. It hasn't been totally solved, but it's been partially solved. So whereas in normal situations where you go to see an out-of-network provider and you don't have an out-of-network benefit, or even if you do, you could still be subject to very high billed charges and cost sharing from that out-of-network provider. But the major surprise billing that was occurring in the nation really revolved around two areas. One is emergency rooms and emergency admissions for when you go through some kind of emergency in life. You can't really plan for that emergency. You may be traveling, or maybe you're even somewhere in your home area and you have an emergency. Well, you're going to go to the nearest emergency room, or an emergency room that is close by that perhaps can deal with your situation. It might be a trauma center. It might be an emergency room that has higher levels of care for more complex conditions, but you're going to be transported likely by an EMS to either the closest ER that may or may not be in network, or another ER in your general area that can serve your acute need. And so in that case, the vast majority of bills coming in really resulted from these emergency situations. And what was occurring is people, they might have had great insurance, they might have had decent insurance, and they were getting bills from these hospitals saying, we're out of network and we are trying to charge you these outrageous bill charge amounts. Sometimes plans would intervene and say, we'll be willing to pay a portion, a negotiated reasonable rate of that bill if you don't bill our member and things like that. In other cases, plans didn't intervene. But generally speaking, those emergency surprise bills were coming in like crazy, and people were going into debt because they could not afford those bills, and they were on payment plans with these providers, or they were declaring bankruptcy because these bills were just simply obscene. The other situation that impacted individuals greatly in terms of surprise billing was when somebody went into an in-network facility. It could be a hospital, it could be an ambulatory surgery center, or a facility like that. And then the hospital or that facility was in network, and even the surgeon that they had chosen was in network. But there were a whole bunch of other ancillary providers that were within the network facility that were providing services on the day of surgery, and they were not in network. This often happens, for example, with radiology, for anesthesiology, for things like that. And so once you had your elective surgery and you thought you knew what you're going to pay to the hospital or pay to the provider, the surgeon, those bills came in, you paid those, but all of a sudden you got a anesthesia bill for some outrageous amount from an out-of-network anesthesiologist, or or another type of ancillary physician that was in the ER, in the surgery suite, or doing something related to that elective procedure that you were having in an in-network facility. And so these two areas, emergency admissions, emergency room, as well as these in-network facility admissions, were driving a great deal of surprise billing out there. So what did Congress do in late 2020, as I indicated? Well, they basically set up a system where these situations of emergency ER, emergency admission, or these in-network elective surgery scenarios, that the out-of-network provider could no longer bill the patient for those bills. They would have to be covered by a patient's insurance plan, and the patient could pay no more than what the normal in-network cost sharing would be for those scenarios. So if you had an ER copay, you would pay that ER copay. That's your liability. If it was an in-network, if it was an out-of-network admissions, you would pay the in-network cost sharing. It could be a per day fee or a fixed fee. And if it was a elective in-network surgery, you would pay whatever your cost sharing was on that. So in essence, the patient would pay what they would assume is their cost sharing for in-network services. If an out-of-network provider was providing a service, too bad, they cannot bill under federal law now the patient, and the out-of-network provider bills the health insurance plan of the member, and it's up to the plan and the provider to determine how that bill gets paid and at what amount. Now, what happens in that case if providers and plans cannot negotiate the payment on that bill, which often happens? Well, what the No Surprises Act also did was set up a baseball-style arbitration, as I call it, that would essentially decide what the provider would get paid. In baseball-style arbitration, there's sort of last best offers that come in from each side, and the arbitrator then decides from the two proposals. The baseball-style arbitration process does not allow somebody to make a decision in the middle, for example. Under the law, the arbitrator is required to consider a whole range of different things. There's something called the qualifying payment amount that can be considered. That is essentially what a median in-network payment might be for these services to that provider. But the arbitrator can also consider a whole bunch of other things: the complexity of the surgery, the cost of the surgery to the provider, as an example, or a myriad of other things, complexity and things like that, that the provider would argue merits a higher payment than whatever the health plan is offering. So they go in and the two sides present their proposals, and they present certain statistics under the law, and that arbitrator then decides what that payment is going to be, either what the provider recommended or what the plan recommended. And so in this way, patients, in effect, were taken out of the middle of these huge, large billed charges that arrived at the patient's doorstep or in the mail. And the patient was taken out of that again, and it defaulted to a process of first negotiation for about a 30-day period between the provider and the health plan. And then if they couldn't decide what they were going to get paid, it would go to this baseball-style arbitration. There are fees that the sides pay into the arbitration, but then that process commences and an award is made after a hearing. Either the provider recommended or the plan recommended, as I said. So again, the law was passed in late 2020. The law went into effect on January 1, 2022, with some portions still forestalled by the federal government. But those main components that stop the surprise billing to the patient and the process to settle what is paid by plans to providers has now been enforced for about 2 years. The implementation of the arbitration process has been rocky. Frankly, it sort of reminds me of what happened with the implementation of the Affordable Care Act website back in 2013 and 2014. So a very, very rocky implementation process. First, the number of cases that the Congressional Budget Office thought would occur in this process was really absolutely wrong. The number of cases are demonstrably above what was projected. So there's a big, huge backlog, and there's a bit of egg on CBO's face here because they were just way off in terms of what they thought were going to be those charges. That said, more and more data is now available that shows how well providers are doing from the process as well. So we'll talk a little bit more about that issue after the break. So rocky process, huge backlogs. This law applies to commercial coverage because by and large, Medicare and Medicaid have rules that protect individuals from surprise billing. It doesn't mean that surprise billing scenarios do not occur with Medicare and Medicaid, but by and large, the large number of surprise billing scenarios that we saw with patients before the NSA was passed and implemented really occurred in the commercial world. And again, that main component of the law disallows providers from billing patients now for out-of-network services related to these emergency scenarios or in-network elective surgery. They pay only that cost sharing and the arbitration process kicks in. The Biden administration actually sought to try to address concerns that awards were going to be very high. If you look at baseball-style arbitration in states that have state laws where surprise billing goes to arbitration and this baseball-style arbitration is used, there was a lot of evidence in these states, including New York and New Jersey, that awards were very provider-friendly and that costs were actually being driven up in the system because providers knew they could get huge awards and demanded even higher in-network rates too. And so what the Biden administration tried to do there was to direct arbitrators to give greater weight to the median in-network payments, or what was known, as I said, in the act as the qualifying payment amount. A court struck that provision in an initial rule outlining how to implement the NSA, and the court indicated that that was outside of the administration's authority and not consistent with the intent of the law. I actually supported the Biden administration's effort in this regard as, again, plenty of data was available from those state surprise billing laws using baseball-style arbitration that indicated providers were winning most of the awards, and in fact, the health laws in those states on NSA were actually helping drive up not only the awards but the costs, as I pointed out. So in this case, in essence, now because the component of the QPA and giving greater deference to it was struck down in the rule, the Biden administration was forced to adopt guidance with very little direction to the arbitrator as it pursues, deciding on something. I will note that providers are still unhappy with the rule that was put in after the initial rule was struck down, and providers are still pursuing legal challenges to the court, legal challenges in court to that second rule that was eventually passed. So right now, arbitrators are left to compare the wide range of different provider and plan data points. They can't favor the QPA by and large, and therefore providers are tending to make out much better within this process. So with that overview of the No Surprises Act and a hint at some of what is happening on awards, we'll take a break right now, and when we come back, we'll go into a brand new study that came out on the No Surprises Act that gives us a little more information on what is actually occurring on awards.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back from the break, and we sort of gave a broad overview of the No Surprises Act, the situations in which the No Surprises Act applies, and we described the negotiation and the baseball-style arbitration process. I alluded to the fact that providers are doing very well in the No Surprises Act arbitration system. We talked a little bit about state laws that have baseball-style arbitration and the history of success with providers, and I alluded to that was occurring here in the national arbitration process as well. So let's get into that now. And so I'm referring to a study from the Brookings Institution. And the Brookings Institution is a very credible organization. I don't think anybody can question their motives or the analysis in this case. It's sort of a center to center left organization. And so very, very credible. And what the Brookings Institution did was analyze arbitration decision data from the first half of 2023. And in this case, why did they look at 2023 data and not back to 2022 when the law started? Well, the fact is that this is the first data dump from CMS. It's only the first half of 23. And CMS likely did not really choose to disclose the 22 data because of all the fits and starts in that year and a lot of confusion. So Brookings sort of only had the first half of 2023 data to look at. More importantly, I want to note that the researchers at Brookings focused on a subset of arbitration decision data. They focused on emergency care, imaging, and neonatal and pediatric critical care. So a subset of these arbitration decisions, but I think it's certainly a credible subset. So what did Brookings find? Well, first, they found that arbitration requests were 13 times greater in the 6-month period than estimated for the entirety of the first calendar year. So again, pointing to the fact that CMO really sort of botched their estimate here. And this created a lot of the churn and problems going on and the big, long wait times to get decisions through the process. Number two, as we suspected, providers won more than 75% of cases in the review period. And this is somewhat consistent with what occurred in some of those states with baseball-style arbitration as well. So confirmation that providers are winning 3 out of 4 cases. And in my mind, that the arbitration process is significantly slanted toward providers and against payers. Next, Brookings found that awards are well above what traditional Medicare and most in-network private insurers would pay providers. Median decisions were at least 3.7 times what Medicare would pay. And more importantly, the awards were well above what traditional in-network commercial payments would be. So in this case, the researchers determined that for emergency care and imaging, the median decisions were at least 50% higher than in-network commercial prices. Next, the study really finds that payouts are closer to historic out-of-network payments, which is very interesting. So the arbitration process hasn't sort of at all found a middle ground, in part because it's baseball-style arbitration, but nonetheless, it hasn't found a middle ground, and that payouts continue to be pretty close to historic out-of-network payments, whether, pre-NSA to post-NSA. They're pretty close. Now, I admit that plans could in part be driving some decisions in favor of providers. There's no question about it. And this isn't a criticism of plans. So plans can only really offer something that is supported by their rates. And their rates are based across the commercial world, generally speaking, on the revenue coming in, and they're based on in-network rates. So it's hard for a plan to have a last best offer in arbitration that is significantly above those in-network rates. Providers, on the other hand, can demand what they want. And therefore, that bias in baseball arbitration tends to favor providers over plans, because plans, unfortunately, have to stay very close to that in-network rate. What was interesting about the data, though, that was disclosed is the researchers did sort of analysis of the qualifying payment amount, which again is the average median in-network rate. Plans are required to disclose this to the arbitrator. And the researchers found that the plan-provided QPAs are at least 35% lower than even the low-end estimates of prior mean in-network prices. So we're not quite sure what payers are doing in terms of estimating these QPAs for the arbitration process. What could be happening, because the study also finds that insurers' offers tended to be slightly higher than the relevant QPA, is that plans are sort of underestimating the QPA, coming in with a last best offer that is slightly higher than that QPA, and therefore trying to look good in the process. It clearly isn't working, because the arbitrators are 3 out of 4 times awarding to the provider's request rather than the plan's request. So just a little more interesting things there. A few other quick points before we take our second break here. Number one, cases were dominated by some very large firms in the first 6 months. And that is, a little concerning to me. And I'm going to talk a little more about that after the break, because in many ways, I feel like that's an abuse of the system. And in many ways, some firms are driving the arbitration process and the awards, and it's very anti-equitable healthcare in my view. But you'll hear a little more about that after the break. We referenced the fact that the study finds that payouts are closer to historic out-of-network payments. I would also note that the researchers say that based on the awards, the amount that a provider could receive in out-of-network situations may not change substantially on average over time. There may be some increases or decreases depending on the service area, but the prognostication from the analysts is that this out-of-network award will essentially stay roughly the same as what out-of-network payments were prior to the NSA. When we get back from the break, what I'm going to sort of sum up here is the real change here. If these out-of-network payments historically are roughly what these awards are today, how are the providers better off? And what are they doing that actually is driving price up because of the arbitration process in the NSA? So we'll cover that when we come back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this coverage of the No Surprises Act. We just concluded our discussion of the Brookings Institution study, which essentially finds, first that arbitration requests are well above what was estimated. Providers are winning 3 out of 4 arbitration cases in this baseball-style arbitration. And we really feel like the awards being made for these out-of-network situations through the NSA arbitration process are pretty equivalent to what out-of-network payments were historically, even before the No Surprises Act. So what does this really tell us? Well, number one, as I've pointed throughout this podcast, this baseball-style arbitration process favors providers dramatically. And number two, what's really going to happen here is that costs are going to increase considerably because of the No Surprises Act arbitration. Well, why is that? Well, we talked about the fact that payments within the arbitration system compared to out-of-network payments before are roughly similar. But in the case of the No Surprises Act, these emergency out-of-network bills, as well as the in-network facility bills from out-of-network providers, are now driven all to the health plans. And the payers have to pay these bills one way or the other. The arbitration process favors the providers in 3 out of 4 cases, and bills can no longer be sent to patients. So in essence, what happens is that these providers can go to a steady, reliable source for income, essentially get payouts that are basically what they were getting before, but they do not have to worry about payment plans from patients, and they do not have to worry about writing off a percentage of these bills because patients will never pay. So the percentage rate of payments will go up to 100% compared to what they will before, and the awards roughly match what the out-of-network payments were before. So in sum, this is a huge gravy train for providers in general, driven by the fact that lawmakers did not understand what they were doing, and they were heavily lobbied by the provider lobby out there, and the health plan lobby essentially got caught flat-footed here. So providers are going to make out like bandits. It's a gravy train. And over time, it will drive up healthcare premiums because these payouts are now, even though they're out-of-network payments, part of overall premium structures. So over time, as these payments mature and the favoritism toward providers continue, we will start to see premiums increase, and we will see overall healthcare expenditures increase. I will also note that what will likely happen here, and we saw this in some other states, is not only will payouts for these out-of-network services increase and stay where they are in the aggregate, but we will probably also likely see in-network rates increase. Well, why will that happen? Because now that providers have a steady source of income and can demand through the arbitration very, very high payouts for out-of-network rates, more and more providers will want to be out-of-network. And to obtain and meet adequacy requirements for commercial laws and things like that, plans will have to increase in-network rates along the way too to meet network and other requirements. So a brand new out-of-network payment requirement by plans, I think it's fair that plans pay it and not patients, but this is something not built into the premium and revenue stream right now. That will force premiums up. And oh, by the way, premiums will probably go up even more because in-network rates will increase over time as well. It's sort of the worst of all worlds that will end up hitting us here. What I think is absolutely astounding about this is just how wrong the federal government, when they passed the bill, had it. The CBO, again, said that the NSA would mean reductions in prices paid to providers, which would reduce insurers' costs and premiums. It projected reductions of about 1%. What's more, it said federal deficits would drop from 21 to 2030 by about $17 billion. And last, the CBO also predicted that decisions would come down close to in-network rates. Well, as the study points out, none of that is becoming true. As I just pointed out, I think in-network rates are going to increase as well as premiums. And the study researchers actually conclude that such awards could do that as well. I want to sort of end on one note here, and I want to talk a little bit about private equity firms because private equity investment in healthcare has become prolific over the last couple of years. Private equity has invested in hospitals, but more importantly, private equity has taken over a lot of provider firms, and many of them are specialty firms that are impacted by the No Surprises Act. The Brookings Institution found that almost 3/4 of the awards they reviewed in the 3 or 4 categories we talked about came from 4 big firms that were private equity backed. They were very much in the specialty service area. And what's concerning to me here is not only do we have a bad No Surprises Act law that was advocated very much by providers and will drive costs up, not only in terms of NSA awards, which aren't in premiums yet, in terms of in-network rates, and in terms of overall costs to healthcare, but we now have private equity firms, in my view, that are taking advantage of the No Surprises Act and playing a major part in driving up costs. And these private equity firms are bringing really no value to the healthcare system. They are using the NSA in this situation, as well as in many others, to the detriment of healthcare overall. There's no way you can tell me that this is not something that private equity has basically put on their agenda and will be using as they take over more and more providers out there. And they will use the NSA as part of their playbook to drive their margin and their revenue at the expense of, I believe, the healthcare system as a whole. So I really think we need to relook at the NSA. We need to make it more of a level playing field. And we really have to get our arms around protecting patients, but not driving up costs in the system as well. With that, we'll conclude the podcast. And thanks for listening in, and take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.